All this is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. So today we have with us Dr. Tommy Zaharakis. He is an internist in Eisenhower Medical Center. Dr. Zaharakis, welcome.
Hi, thank you. Thank you, Dr. Mobeen. I'm a internist by training in allopathic medicine and also have a specialty in nephrology that deals with kidneys, dialysis, and kidney transplant. But lately, the last 5 years, I've been doing more internal medicine, direct hospitalist work, and taking care of patients admitted to the hospital.
Got it. So tell me this for today's interview, just to set the stage, in terms of COVID and then in terms of monkeypox in that context, what is your day-to-day exposure? How much involved are you in the management of these? Tell me a day in your life for in context of these two.
So I work mostly at night, but that gives us a lot more freedom. But my interaction with COVID, started early on in 2020. We had one of the first COVID positive patients in Southern California. Subsequently, we had several surges throughout 2020, 2021. We were directly dealing with treatment, initial evaluation, emergency room, treatment, management of these patients. Fortunately, in the last 3 to 4 months, COVID-19 has changed dramatically in terms of being less of an inpatient disease, more of an outpatient disease. And with that, the management has been more advice to patients who present to the emergency room with COVID or from COVID, and recommending treatments, forthwith there. Um, the good thing about the recent developments with antivirals is patients have been able to stay out of the hospital. And we haven't had really that much in the way of COVID-19 admissions for COVID. The difference is when someone is admitted with COVID, an incidental finding. We test for patients coming into the hospital and we find that they're COVID positive with one of the Omicron variants, and they are largely asymptomatic.
Got it. And so a couple of things. Number one, for the audience here, when I am looking this way, the comments that you guys are writing are here, the Cool Beans comments. So if you have a question for Dr. Zaharakis, do me a favor and write QQQ or something like that so that I can pick that up in the comments. Dr. Zaharakis, I believe when he is looking downwards, probably that is where your monitor is.
Yeah, just right in front of me.
Cool. So that is just a quick update for the audience. Would you like me to share your slides and we go over them as well? Or would you like
Sure.
to discuss them whichever way you like? So here
Yeah,
we are.
sure. I think we can go through the slides and just take us along on the treatment of COVID-19, how we were doing it here in Southern California, and going from there. So this first slide, um, you know, the towards the beginning of the pandemic, it was apparent that timely treatment of COVID was imperative. We local doctors, practitioners had to fill in the gaps because really there was no protocols or other treatment modalities already tried and true for this particular virus. We had instruction from MERS and COVID, SARS-1. However, it really was an adventure in uh, diagnosing a new disease with new symptoms and new side effects and sequelae of treatment.
Got it.
Yeah. So within the first, I would say, 6 months, uh, you would see this in the literature where we delineated the different phases of COVID. I think it's very instructive. The viral phase, in the beginning, you'll have symptoms or not, typically fever. And I'm going back to pre-Delta uh, and Delta COVID-19. That's where the majority of the viral load will be generated. Um, and at around day 7, towards the end of the viral phase, is when patients would start to present. They would present with new symptoms, shortness of breath, occasionally chest pain. This is the beginning of the cytokine storm phase. Uh, Usually, if they're admitted with hypoxia, and usually it's less than, with a O2 saturation less than 92% on room air, we will admit them to the hospital and begin treatment. Shortly after that cytokine storm phase is the coagulation phase, where we see a lot of this bad sequela of COVID, strokes, heart attacks, multi-organ failure, and then subsequently, in the patients who do poorly, we see a late hyperinflammatory phase where the immune system that is out of control goes into overdrive and does the most amount of damage for patients.
Got it. And a couple of questions as well. So in our discussion, we'll continue to add in the question too, because we are live. So here is a very interesting question. I have a question as well. And the question is this: in the recent times with the COVID, do you see more outpatient patients of COVID developing cardiac issues? And do they then resolve or not resolve? Have you seen this?
Well, an interesting thing, and I think it will take to first start your answer. What we have noticed is a large uptake in our volume, a volume that cannot be explained by, normal patterns, holidays, or ongoing. In our area, we are very seasonal. However, we notice a large increase in patient population outside of COVID that are not COVID positive. And the sequela, the diseases we're noticing are strokes, heart attacks, occasionally kidney failure, occasionally very, very unusual clotting. I think that a lot of practitioners are putting their heads together and analyzing this and looking this as a post-COVID, hypercoagulable phase that we're seeing in patients who may have been positive for Omicron and recently and not known it, or asymptomatic, or had the disease and recovered. So that's the only explanation we can make for the large uptake in admissions and visits to the emergency room. We're talking about 20 to 25% over a typical year, and that's pre-COVID. It's well outside our norm. So we've been working hard on this.
Got it. So then I have one more question. This question is from, and thank you very much for the answering. This question is from Irish One. They say that Dr. Zaharakis, do you know of any transplant patients who have lived after getting COVID? How about non-vaccinated?
Yeah. So yes, the answer is yes, and there's some unique things that about transplant patients. Number one, they tend to be monitored a little closer by their doctors. Number two, they have available. We have a monoclonal antibody that's available called EVU Shield. It's a monoclonal that protects against still the variants that are out there. Even in the non-vaccinated era, we see that some of the anti-rejection drugs that they're on likely are protecting them. We've had patients who are transplant patients that have a prolonged positive state, and then we deal with that afterwards. But relatively, the transplant patients, and at least the ones I've seen, I think have fared pretty well.
Good to know. Thank you very much. So back here, we'll look into the so cool beans. We'll look into the questions a little later. I want to mix the progression of the instructions today by Dr. Zaharakis and your questions. So okay, back here to this one. If I then go to the next slide.
Yeah. So this slide is very busy, but it's the slide that I love because it really gets in there all the things about COVID and its explanation. Particularly if you look at the yellow and the red markers there. Um, Typically, we're going to see patients a week prior to those, so it's the week prior. But these are in this area is where we're going to start doing our major treatment for COVID, which includes steroids, specifically dexamethasone, other immune modulators like baricitinib, um, and these treatments help turn down the immune system over this inflammatory phase of COVID. In addition, the anticoagulation, in general, we tend to anticoagulate hospitalized patients to prevent deep vein thrombosis, which is um, a disease that happens when you're sitting idle. Your body can tend to clot, especially if there's infection. So adding the anticoagulation there is a mainstay of our treatment.
Got it.
The last phase, if you can see the hyperinflammatory phase, these are patients that enter really are from ICU patients. But one thing that it's important, in the green area, is the problem of when you're impairing the immune system, there are sequelae in terms of the patient may require additional courses of antibiotics and antifungals. And many of the COVID patients had trouble, those who beat the odds and were able to recover, only to return to the hospital with other comorbid infections. The One of the drugs that we use that is very effective, Tosoluzumab, essentially knocks out T cell immunity for about 6 weeks. So that impairs patients and leaves them open to things that are in the environment.
Got it. Very good. Thank you very much. And if you don't mind, I'm going to once again ask two more questions. So this is the
Go ahead.
flavor Dr. Bean Live. So here is a question from Patty Zig. They say, if you have had chicken pox and inoculated for smallpox, do, do these product do these protect you from monkeypox?
Yeah. So the inoculation for smallpox, and if the generation that had it in the late 70s, there are some that may have had it even as late as in the 80s. It's questionable whether that's going to be protective or not because of the time and years that have gone by, the immune system unchallenged. But in general, should be ahead of the game. Theoretically, it shouldn't be worse uh, or than the other parts of the population. I'll go over the monkeypox later,
A
some
little
other
later.
things that we found. So,
Okay, makes sense. One more quick question. Jim Merrick says, is rapamycin helping those transplant patients?
yeah, so rapamycin is a marvelous drug that some patients are on. Um, we rarely change the immunosuppressant that the patients are on, and there's usually a good reason. There would have to be a organ rejection issue, but there are special things about Rapamune that get very complex. But this particular drug has a lot of benefit outside of just immunosuppression uh, for a particular transplant patient.
Got it. Thank you. One more question, then we'll go back to the slides. Texas Max says, are you wearing N95s around patients? I'm trying to figure why most hospital employees are not wearing N95s. So I'll leave the second part. The first part, how is the mask policy over there?
I mean, unfortunately, I haven't come down with COVID. I think I've been really careful. I use at least an N95 or more. I have a specialized mask that I'm working a 12-hour shift, so I have to, get some assistance there with a more expensive mask. But in our facility, uh, in the patient areas, the N95s are used, and the good thing is the supplies are plentiful now, so we don't have to downgrade and choose inferior masks. The surgical masks are more appropriate for the public areas. maybe the places to and fro from the patient areas, but anybody with patient interaction is going to wear an N95. And actually, when the patients transport, they also wear an N95 mask.
Got it. Thank you very much. I'm going to go back to your slideshow. So, benefit of therapeutic
Yeah.
classes.
Yeah. So again, this is just a delineation of the different phases of COVID and the different symptoms. Early on, you'll have fever, dry cough, lymphopenia. Um, this is the stage where antivirals will work. Um, Unfortunately, because of the confusion throughout the pandemic and no clear, strong voice on treatment, a lot of practitioners through trial and error have, found that that you can't use steroids early on. Just because they use them in the hospital, you'll cause damage because you're impairing the immune system at a critical time. In the pulmonary phase, however, that's when you're going to be using the drugs that are going to be more helpful for inflammation and preventing the body's host defense from its autoimmune reaction that gets set off by COVID. At that point, although the antivirals are not that effective, and one classic one the big controversy is remdesivir, where patients, remdesivir is an intravenous drug and requires the patient be in an area where they can get one. You would have to be admitted, and since patients don't present until day 7 and 10 for Delta, they weren't able to benefit from really remdesivir. Only a small portion of the curve where they can get antiviral effects for remdesivir. So that's just an example of where the drug is and where it's most effective. There is remdesivir outpatient now. There's not been used that much. It's still a lot more difficult than an oral antiviral. So
Got it.
last the inflammatory phase. This is for the severe patients that progress to ARDS, and the trick is to prevent this stage from happening, because really we don't have a lot of tools to reverse this once this starts and sets in.
Yeah, that is a concern. And these stages and the approach, is that also true for Omicron, or
So
Omicron symptoms and behaviors are different?
Omicron, the hyperinflammation phase is a lot more rarer. Uh, the pulmonary phase, we're having some patients, but a small fraction of what we had in Delta. Uh, Really, what we're having now, and I think that has to do with likely where the virus is able uh, to get into and infect and cause problems. In a lot of ways, Omicron cannot really affect the lower lungs, and that's shown by the patients and how they're doing, vaccinated and non-vaccinated. So we don't see that much in terms of the hyperinflammation phase. I would say, however, that I think there's always a chance with, with how the virus is mutating and changing. I think we should always be vigilant about this and not just chalk it up to it's never going to happen again. I think we should be prepared for that. And there are other viral diseases that cause this hyperinflammation. Rarely a flu will do this, and RSV will do this as well. Uh, so I think being prepared and knowing how to handle this and having tools in your toolbox to treat this is an important thing, and where a lot of research is being put now.
Got it. Thank you very much. And for the cool beans here, we realize that there are people who are still ending up in the hospitals, ICUs, ventilators, unfortunately, people who are dying too. The fraction, the percentage, the numbers may be lesser. And the second thing that is very interesting for me, Tommy, is you mentioned that Omicron mostly towards the upper respiratory. That is your clinical observation. There had been
Absolutely.
a couple of studies, one from Japan and one from which one was it? One study was from the US that said that um, in vitro studies, where they said that Omicron actually is much better to infect the lower respiratory tract. And based on that, they said, well, we have a problem that is coming our way. So clinical observations are slightly different from in vitro observations.
Absolutely.
Okay, so let's continue. Here is another.
So here's an example of a CT scan from the Delta time, where we can see an example of someone who presented. This was a younger patient, presented with a large oxygen need, was needing at least 10 liters of oxygen, and has a real, both lungs affected by the inflammation. What these very white patchy areas, the darker areas would be normal lung. And what one of the features of COVID uh, and was in the early pandemic, before we had a good PCR test that had a good turnaround. Uh, we used CAT scan very often and was very reliable and been shown to be almost just as good as doing a PCR for COVID, especially the Delta and before variants, where we can diagnose it and start treating patients, not waiting for a test to come back and to confirm it. So CT was a very useful um, tool. The way that now that the way that radiology is set up around the globe is specifically at nighttime, we have radiologists across the world reading these exams. And I can recall a physician, a radiologist from Italy, calling me to tell me about this and how they were being affected by this. And I think he wanted to vent too, but he wanted to let me know that this definitely, from his eyes, looked like COVID pneumonia.
Interesting. So, just for the viewers, this little whole structure here is lung, and this front part is blackish, and that means it is kind of normal, and this whitish part is
Mm.
abnormal. Correct? Is this the correct way to look at it?
Yes,
Or
absolutely, absolutely.
okay, excellent. Thank you very much. So then here,
Yeah. And just to go over what the NIH put out guidelines of what's mild, moderate, severe, and critical. The numbers really don't make much, for the average person aren't that important. But it help us to, when we talk about patients, we're all talking about the same type of patient. So this specifically severe illness where the oxygen saturation is less than 94 on room air and a high respiratory rate. This is the patient that we would see in the emergency room 7 to 10 days after COVID, becoming having symptoms. The moderate illness, the one above where the stats were above 94, uh, they were able to be sent home with observation. Occasionally, during very busy times, we'd actually send them home with oxygen, a few liters of oxygen, and monitor them uh, due to the hospital being full, overrun. That was a very rare occurrence. So,
got
uh,
it. Thank you very much.
and FDA finally put up some guidelines about who was at risk to progress to severe COVID. This is again in the pre in the pre Omicron age, but even with Omicron, can be instructive and who's at risk for possibly developing further complications. And they go with elder age, obesity, diabetes, someone who's immunosuppressed, underlying cardiovascular disease, and other diseases of oxygenation of lungs, especially sickle cell disease, and other diseases where they have trouble uh, normally changing their respiratory rate. Someone may have a partial paralysis or has respiratory compromise or needs a ventilator.
Got it. Thank you very much. And once again, a reminder for the audience, for the cool beans here. If you have a question, just prefix that with a few cues so I can look at them. Okay, so next slide.
So just go down the memory lane with the treatment for COVID, and we're talking where this kind of treatment kind of solidified from about June 2020 to currently, just a few months ago, where we were seeing still some patients that needed admission. The mainstay was dexamethasone, and these patients would get dexamethasone if they had hypoxia. Any amount of oxygen need, that would be an indication to have dexamethasone. If someone was not requiring oxygen and or not have any infiltrates that would be seen on an X-ray or a CAT scan, we would not start the steroid therapy. Next is azithromycin, which by itself has anti-inflammatory properties on its own as an antibiotic, and it covers a good amount of bacteria for pneumonia. Ceftriaxone is a cephalosporin that we also add for community-acquired pneumonia. Often this was given with the dexamethasone as treatment based on the patient's risk factors and other comorbidities. Next, an important thing that we picked up, I would say, several months into the first wave was we noticed that, histamine blockade was very, very beneficial. And I think there's data that shows that histamine blockade has a lot of effects on macrophage aggregation and the inflammasome dealing with COVID. So that is a mainstay of the treatment. The good thing about it is it's low cost and very low in side effects. And these are both over-the-counter drugs. Next, we have inhaled beta agonists, and we would combine them with other agents, and one's typically used in asthma. Melatonin was a mainstay because of the insomnia that happened with patients up desperately trying to breathe, but we found that it had other benefits, so it was part of our regimen, and other groups that were publishing their protocols were including melatonin. Vitamin D was important, and also calcium. In the state of vitamin D deficiency, we would give synthetic vitamin D calcitriol to assure that the patient would have available ready vitamin D. This is the vitamin D that the body can use that does not need to be converted, in opposed to like a vitamin D2 that needs to be converted in the body. Next, something that was added from the RECOVER trial was fluoxamine.
Fluoxamine was. I'm so sorry for interrupting. So fluoxamine is in use in your.
Well, we had been using fluoxamine probably since August of 21. Maybe when the RECOVER trial data was published, it's low side effect, and the action of I believe it's the sigma receptors was beneficial. Any advantage someone would have coming in to decrease ICU, what possibly of needing ICU, and decreasing hospital stay. And I think the fluvoxamine did show that. So we were utilizing that as part of the regimen, unless there was some contraindication.
Very interesting.
As a kind of the next step above steroids, we have Tosoluzumab and Baricitinib. Now, Tosoluzumab is a very powerful immune modulator. However, it's very expensive and it's hard to replicate. And it's not. And during the pandemic, we had run out of it many times. So Baricitinib, which is a JAK2 inhibitor, it took the place of Tosoluzumab and had also efficacy to control the immune system. So often, and the added advantage is when you discontinue the Baricitinib, the immune system rebounds. So it has a lot of implications for the fungemia and the other bacterial pneumonia problems post when the patient's in the recovery phase. So the baricitinib was really used for the moderate to sub-severe patient, where the tocilizumab was really reserved for the ICU patient going to the ICU. Next, we have Rendezvir. Um, so when this was the first treatment, antiviral treatment to come out. Um, when we were using it, especially when there was a worsening O2 requirement. Now, Remdesivir is also available as an outpatient as well, and this drug will use in concert together with dexamethasone, but never alone. We would never give it by itself. So it has efficacy. I think in the beginning, and we have give it credit that it was one of the first things that we could use, but uh, there are clearly other things that we're using for the patient's care. And last, Lovenox heparin anticoagulation for the patients when they're in the hospital to prevent the clotting sequela from COVID.
Awesome. Thank you very much. I am actually as much as people might be thinking that we have the slides here and not just talking, this is a gold mine for practitioners. So thank you very much for doing this. You've done a lot of hard work to put it together. I want to ask you some questions as well. So here is I saw two questions that scrolled up. So I'm going to go upwards. And so latest question here. John says, has a good doctor used international um, business machine? Is there any international wuziness machine? I didn't understand the question. Okay, so then going to go up and ask this question. Texas Max says, can budesonide be delivered too early during infection on for long COVID but had BA5 in Miyagi?
So I think that what would be instructive there are patients who, especially with asthma or with COPD, who utilize budesonide as it's a inhaled, can be an inhaled steroid, and we haven't seen any sequela from that. At least I haven't. So can you give budesonide early? It's not an appropriate drug for prophylaxis unless you need it. But I don't think it has been, these inhaled steroids have shown to cause an increased severity of COVID in patients who have been using it. So I think that may be the angle that was asked. I think, if patients require it for their COPD regimen or asthma regimen, taking it didn't have an extra cost for them.
Got it. Thank you very much. There's a monkeypox question, and if this is coming up later, then that is totally fine. Manuel says, our pediatrician told us we passed chickenpox immunity to our child 21 years ago. Is this still fact, or has recent research proved different?
So I want to put a line between chickenpox and monkeypox. Chickenpox, varicella zoster, passing the immunity is not hereditary. Um, Nowadays, children are getting the chickenpox vaccine. When I was younger, I had chickenpox, and usually children get it when they're younger. It's encouraged. There had been a paradigm shift in pediatrics to vaccinate children against varicella, with the cost of now these children have to maintain their immunity. So if their titers were to come down, they would need a booster for that chickenpox.
Got it. Two more questions. And these are long COVID, and long COVID patients are suffering. So here is Augie says, any full recoveries from long haul?
Well, in my sphere, I've known some physicians with long COVID who, took time off, improved their diet, changed some things about their regimens, and had some improvement. Anecdotally, I know people using uh, herbal anti-inflammatories that could be helpful. Um, the symptoms for long COVID are varied, so um, they go from respiratory to energy to even mentation. So I think it's a big a big basket there of patients, but I have seen patients improve from it.
Okay. One more long COVID question, then we go back to your slides. Alexander says, "What is your approach for long COVID?" So, do you manage long COVID?
I not specifically, but I would say that you would have to go with the disease, the complaint the patient has. It goes very close to what Epstein-Barr virus uh, fatigue would be if there was to be fatigue. There are a few referral centers that are now specializing in it with special lab tests and looking at specific cell lines that are activated. So I think I've seen patients go from getting, if they have secondary COVID, even patients who thought they had long COVID were really experiencing another infection, an Omicron or a Omicron again. So it's very varied. And I think the long COVID story is now is being written. Practitioners are now treating patients and addressing their needs. I have seen patients get fluvoxamine long term, and I think that this is an anti-inflammatory. And I've only heard anecdotally about it, but not treated patients specifically.
Got it. Thank you. Two more questions, then and then we'll go back. One
Mhm.
question is John Snyder says, same question, but for dysautonomia. I think he may be talking about the management of dysautonomia in long COVID. Have you seen dysautonomia in long COVID, and how do you approach it?
Absolutely. Well, in terms of if for cardiac, if it affects an elderly patient, they may require modalities like pacemaker. They may require different changes in their drug regimen for drugs that may actually, uh, in the normal state, not affect people, but when added to uh, the dysautonomia of COVID, caused a lot of problems. So it means managing changes in their drug management, and regarding dysautonomia, there's some when it's caused by other things other than COVID. There's approach from maximizing you know uh, the change the preventing the change in systolic blood pressure from sitting to standing, and also other kind of biofeedback training.
Got it. Thank you. One more question, then we go back to the slides. Tiny Smith says, "Can you get monkeypox more than once?"
Well, so I think it goes back to the question too, because monkeypox and smallpox are very similar in this orthovirus family. Can you get them twice? I don't see any reason why you couldn't. It depends on your host immunity. Um, if your immunity was down and decades later, you can get it. But uh, I think we're coming to a point where if someone would be vaccinated or to have a prior infection, my impression is that you would probably be protected against monkeypox unless it had changed radically or mutated.
Got it. Makes sense. Thank you. So going back to the slides,
You know.
COVID-19 treatment consequences.
Yeah, so there are some consequences to the treatments that we had, and we were adept to handle them. The biggest one was the glucose tolerance issues. Patients who had not been diabetic, some requiring insulin because of the steroid treatment would be the most common problem, which is manageable. Another problem is Clostridia difficile colitis, which is a consequence of antibiotic therapy, where the bad bacteria Clostridia difficile multiplies in the gut and can cause a pretty bad diarrhea and colitis, and we manage that as well. The other issue is fungemia, which is from the immune suppression, and it can pop up months later because of the impairment of the host immunity, specifically with tocilizumab, and those patients have to be followed and treated appropriately, and not just blaming it on their COVID diagnosis. Last is bleeding from anticoagulation. This is a consequence of the blood thinners that we give. Occasionally, there's bleeding, and we have to manage that risk there.
Got it.
Okay.
So this is pre-exposure prophylaxis.
So this kind of mushes through and molds over into the turn time period where we had the pre Omicron era, which had sort of a different treatment. But what we have now available is AstraZeneca's EVU Shield, which is passive immunity with two monoclonal antibodies that are still effective against the Omicron variants. Other things that we were giving advice to patients are nasal barriers. These would be nasal sprays, washing out their the cavities if they're around people, mouthwashes and lozenges with cetylpyridinium chloride, which is a common mouthwash. Other advice is zinc and vitamin C, adequate sunlight, exercise, not being a shut-in, not kind of breaking through that shell from being locked down. Other things that could have some benefit were quercetin, luteolin, green tea, some flavonoids, which seem to help in viral infections, lactoferrin, turmeric, curcumin. Actually, there's at least one paper that showed very good results with turmeric and Omicron. And managing diabetes, especially because those patients are more at risk, and any way they can manage inflammation will help them in the pre-exposure prophylaxis kind of realm.
Got it. Thank you.
So, post-exposure prophylaxis for someone who's not hospitalized and has been exposed, we have the only real monoclonal that's lying that's still able to manage the Omicron variants is bebtelovimab, and it's available. The stocks are adequate. Mostly because of Paxlovid, that the reliance on monoclonals has been much, much less. And again, the nasal barriers help, especially after a exposure. And the same with that sunlight, flavonoids, lactoferrin, all can help after you've been exposed.
So you brought up Paxlovid. As much as Paxlovid has become mainstream now, what is your understanding of the rebound? Is it the virus still hanging out there, and the drug was
So
prematurely?
what Pfizer is saying, it's compliance issues where it doesn't even have to necessarily be that. So the Paxlovid, like my impression of it, um, is two drugs in one. The ritonavir is there to boost the level of the other antiviral. Now, there you can imagine a myriad of different gut scenarios where it's not absorbed correctly or not done in a timely way, and your level can come down. So I think that for the most part, it's a very effective. We haven't seen resistance to it. However, I think this rebound, is likely is I would say probably from uh, compliance, but there still could be some problems with absorption that haven't been kind of fleshed out by the drug company.
Got it. Thank you very much. And please, for the listeners, if you are going to be adding your own protocols here in the comments is not the place. So I would request you to stop. Back to you. So here is
Oh,
Paxlovid.
okay. So Paxlovid, kind of an exciting antiviral because it's available for patients to take at home and not requiring it to be in the hospital. And they can take it in a timely manner after they're tested from either a PCR or an antigen-based test. But the trials had showed an 89% reduction in hospitalization and death, and these were Delta numbers, not even Omicron. But we see that the efficacy kind of pushes on through to Omicron. Now, when we have a low hospitalization rate, what does that mean? I think it's beneficial for the elderly, especially people at higher risk who can benefit from the drug, even if the hospitalization rate um, uh, without Paxlovid is relatively lower compared to Delta and the wild type COVID. Um, it's not approved. It's an EUA drug. You have to have symptoms within 5 days to qualify for the Paxlovid. Um, there are some concerns and considerations for patients on other medications, specifically anticoagulation, which is a common medication like Xarelto. There has to be some accounting for that if someone is on that. The president, I believe, was on Paxlovid and a factor 10 inhibitor. Many practitioners choose not to give Paxlovid for patients with that and may choose molnupiravir, for example.
Got it. Thank you.
Okay. And we have the CYP3A metabolism. It's a complicated liver metabolism for patients who couldn't need Paxlovid. For example, warfarin, if they're on that anticoagulant still, they would have to have that monitored. There's also issues with drugs like digoxin and quetiapine, which is Seroquel, which can increase the level. Patients on drugs for pain, such as fentanyl, you can find the level increase quite dramatically. So those considerations have to be met.
Got it.
Okay.
Or understood. So
Yeah.
my Cool Bean team sometimes makes fun of my got it, and some like it as well. So I sometimes try to now say understood or interesting.
Yeah.
So
Yeah, this is some. We don't have to spend too much on this. The remdesivir data. Um, Remdesivir now is available outpatient. How since we have these other drugs, it's available. I haven't found a use for it yet. It would have to be in some patient who could tolerate these other drugs and would require them at home. I think it was the next logical step for the drug company to keep it in the treatment arm there. But right now, it's not something that's typically used that often.
got it or understood.
Yeah. Okay, we can skip here past there. Yeah, let me go back one more. This is the bebtelovimab. This is the monoclonal antibody against the Omicron uh, variants. It still has efficacy. Um, this It's available for patients who are not vaccinated with concerns and health concerns. This would be something that would be made available to them to prevent hospitalization and progression to a worse outcome. So I think it's a good thing we still have this monoclonal around in addition to the antivirals.
Understood.
Okay. Just the take home points is to get the patient diagnosed and treated as quickly as possible. Um, uh, all the therapies that we have are associated with a reduced in hospital and death, and unvaccinated persons, early infection. The monoclonal antibody selection based on neutralization of currently circulating variants. So we may lose this particular monoclonal at some point. Hopefully not. Um, the the consideration of the drug interactions by Paxlovid with adjustment for renal dysfunction. There is renal Paxlovid now that's been put out by the drug company, so it doesn't have to be compounded. Molnupiravir, and which I had not mentioned before, there's some potential for mutagenesis and with patients who have childbearing potential. So generally avoided in those patients.
Excellent. This is really great set of information. Thank you so much. So before we go to the monkeypox, I want to ask the cool beans here for any questions on the COVID side before we go to the other one. And my request to the cool beans, I'm seeing some questions that I'm ignoring. So you and I both know that there are some drugs that I just cannot discuss them here. So if you are putting those questions out there to be facetious, I'm fine, I understand it, but I won't be able to ask those questions. So after those, let's see what other questions are. This is a question I actually didn't understand it. So Vapa Bamir says, any studies on effectiveness in vaccinated patients? I didn't understand it. Effectiveness of what?
I think maybe so. The studies with Paxlovid had
Oh,
been done in unvaccinated patients, and
oh, I see.
I think that we're having data coming in, and I'm pretty sure that we'll have an update from the CDC about Paxlovid for patients who are vaccinated as well.
Got it. So this is actually very, very interesting. So thank you for catching that. Uh, some more questions. Irish says, do you have to adjust immunosuppressants on Paxlovid?
Some do. Depends on immunosuppressant, and if it goes through the CYP3A pathway.
Got it. Let me just see. So there don't seem to be more questions on the COVID side. My question to you, you have been managing before, you're managing now as well. How do you see COVID nowadays? Is it um, less severe, more severe, similarly severe?
Well, there was in this part of the year, I had been admitting 3 to 4 COVID patients a night. I can tell you that I haven't admitted a COVID patient in probably 3 to 4 months. This is someone who's admitted for COVID. There are patients that are admitted for other reasons that will test positive, were asymptomatic, and that is the norm. So I think thankfully it's become a less severe uh, illness. However, we have to be vigilant about the fact that it's going through the population. Prior infection doesn't seem to be protective for another Omicron infection with another variant. So I think that being vigilant about that. The vaccination data is still forthcoming on whether vaccination is beneficial for Omicron.
Got it. Thank you very much. One more question, and then we go to the monkeypox. So Kelly says, does the name sudden acute respiratory syndrome continue to fit the current variants? I think it is severe acute respiratory
Yeah,
syndrome.
severe. Yeah.
So do you feel it is still SARS?
It doesn't feel that way. It doesn't feel that way typically, but I think a name change at this point would be problematic. I mean, even the the variants have come so far away from wild type Wuhan COVID that one wonders whether we should be calling this SARS-CoV-3 The
So
naming the naming is up to consensus, and I think maybe retrospectively it'll be changed.
makes sense. And I had made this comment as well that usually the variant name change or species name change appears when there is a lot of genetic mutation or phenotypical mutation. And phenotypical mutation would then play into the clinical outcomes. And it seems like Omicron's clinical outcomes, as much as it is still respiratory, it can still cause hospitalization, ICU deaths. However, it has changed a lot. So it may, the way I see it is that if I'm writing a book about SARS-CoV-2, I will have to keep saying if we are talking about Delta and before or Beta and before,
Right.
then the symptoms are these and management was this. If it was Omicron and then this, that already means if I have to do this, if, that means these are two separate things. So very interesting. And yeah, they are not touching it. Okay, so I'm gonna go to the monkeypox. Okay.
This is just some information I put together for monkeypox. We're at this point having um, several admissions or presentations to the emergency room a night. None have yet to be admitted. And for the most part, it's the monkeypox seems to be um, concentrated in the community of men who have sex with men. Um, but there have been outbreaks of monkeypox in the past, uh, some from pet animals that had come from Africa. And those outbreaks had been contained. But just to go into some background information, the human monkeypox is caused by a virus belonging to the orthopox virus genus. It was isolated from primates in the 50s. In 1970, human monkeypox was identified in the Congo, and since then, there's been zoonotic outbreaks through humans. In right now, our current situation is smallpox had been thought of as a disease that was declared extinct, and this has left the CDC without a large supply of vaccine and antiviral, unfortunately. And I'm presume that the COVID-19 uh, epidemic has caused priority shifts away from keeping stockpile of these antivirals and or the vaccines on hand.
Got it.
So monkeypox clinically causes a smallpox-like disease, a rash, fever, respiratory symptoms, pain at the area where the pustules are. Um, Except for there's a marked lymphadenopathy in humans. It varies biologically and epidemiologically. So it seems that the outbreaks from the zoonotic outbreaks seemed a little different than what we're currently experiencing. It's unknown if the prior smallpox vaccination from prior decades will provide protection or any kind of advantage. And since monkeypox clinically causes a smallpox-like disease, um, I think I must have repeated this again. I'm sorry.
So then tell me this. I have this question, and for the hospitalists, how do you? So let's say you are practicing, you are in the hospital, you're seeing patients, and all of a sudden you suspect this person may have monkeypox. Question for you. Number one, are there actually situations where the person is not aware and you were there are no pustules, it's nothing, but you suspect this is monkeypox? Number one. Number two, what do you do? Do you quickly quarantine? Do you wear PPE? What is your protocol?
So far, the patients presenting with pustules, some are presenting with concerns about exposure. I think the if this had occurred at a time outside of COVID, we may have had it in a different situation, because now all the patients coming to the emergency room, have to have don masks. The staff is wearing masks, so we're at a heightened level, a level that we never really had had experienced or practiced before. So we're not really seeing the respiratory component of it, and it's thought that it could be because smallpox is, but all the prior outbreaks had really been surrounding, initial zoonotic, you know,
Pathogens.
contact, and then spread really by the animals, not human to human. Now we're seeing the human to human, and it seems to require a lot of close contact for transmission. I think that's a good thing. Um, at some point, we may start to experience patients with the prodrome first, with fever um, uh, and lymphadenopathy before the pustules, but typically they're presenting with this to the emergency room with the signs of the rash.
Got it. Thank you. Understood.
Okay, we can move on to the next one. So the pox concentrate mainly on the face, arms, and legs. A negative and a positive because it becomes obvious to the patients that they may be exposed. Um, 95% of the cases are developing the rash on the face, which is interesting. 75 have lesions on the palms and hands, and the lesions on the genitals were only about 30% from prior outbreaks, but the numbers are seemingly higher in this outbreak. Overall goal is not to admit the patients because of the isolation concern. Um, because of the treatment is mostly self isolation and treating the pain associated with it, and for patients who are at risk to be treated with the antiviral.
Are the patients developing scars at the end of the disease when they recover?
It seems so, and I think it from the prior smallpox experience, the lesions after the final kind of scarred off lesion can the area under the dermis can indent, and you can have a classic pock mark scar. I think the jury's out on that one. I think the prior um, uh, outbreaks, the people have had the monkeypox scars were readily avail. You know, you could witness them years later. So.
Got it. A couple of questions that are interesting here. Tiny Smith says, story in news today. Cashier thinks she got it from handling money. Possible to.
I to, Currently the outbreak has been really close contact. I mean, I would have to. Um,
You will have to actually see what were the circumstances of
yeah, we
money.
have to see what the symptoms are, but handshaking could be so money. Money changers are at risk for a lot of things, and I would be suspect of that, but it's possible.
Got it. And then the Denise TG says, are you observing lesions on the feet?
Yeah. So there are this particular rash is a little unique in terms of rashes. The rashes can be on the palms and also the soles of the feet. And one of the patients that had come in had difficulty walking because of the lesions on the feet because they were so painful.
Understood. Two more questions. One question here is MGW. So this is Omicron and BA5, but still interesting. Are you seeing still majority older patients with comorbidities during BA5, or is it equal across ages?
So it seems to be more the elderly still who are having trouble with the current Omicron 4 and 5. And I think specifically when these patients are at risk for other things, strokes and heart attacks. So they often will be coming in with a stroke, and we'll find that with COVID now, it's hard to say what is the stroke from the COVID, or is it just a asymptomatic infection. But definitely, the older patients are having much more difficulty with the Omicron. You know, just as in a flu or common cold uh, epidemic.
Got it. So I'm going to ask a couple of questions. You can totally skip on it if you like. One question is from John. Do you think that we are at an emergency level in the US regarding monkeypox? And the reason I offer you to skip if you like, because the health authorities have said it, you're working in that system. So totally up to you.
Yeah, I mean, so far, the United States has declared a health emergency, I believe, for monkeypox. So I think that uh, in terms of as an emergency, it is. I think that quite different than COVID. I think it's more contact, and at this point, um, uh, dealing with close quarters to someone who had been who is infected. I think, in the short period of time, modifying behavior could yield a lot in terms of prevention here, at least unless something changes about the virus. So I think for it, as far as the authorities have declared it, I would agree to have vigilance so it gets into the public.
Got it. And I think you kind of answered the next question. Dr. Iron Mom said, how is transmission occurring? Is this an STD via semen or skin to skin contact? Something else?
It seems to be both. It
Hmm,
seems to be both.
hmm. Very interesting. Thank you very much. And if it is via semen, would this also be then saliva or respiratory droplets?
It seems to be more saliva. Researching back into the prior outbreaks, one outbreak started when a child got a pet that came from Africa, and the rodent bit the child, and she had the first sentinel kind of monkeypox lesion, which always is a little bigger than the other lesions. And so it seems to be saliva.
Got it. This is an interesting question. Idania says, how long does the pox last on doorknobs after a person doesn't wash their hands?
I I think that's yet to be determined. Um, in the history when smallpox even was in the United States, and even before they knew of the modes of infection and transmission, the whole towns were quarantined. So I think that there's a possibility of something being on the surface. I think with COVID kind of vigilance, I think a lot of those concerns are kind of be can be assured there.
Got it. So I was cracking up about this. Alexander says, I hope there's no transmission via post office pens. So that is our internal
Yeah.
joke, because I actually think I got my first COVID infection from a post office pen. So, well, if I got monkeypox, I'll blame it on the post office pen and not tell you anything else. All right, let's go here and then go to your next. All right, so here we are.
Okay. I mean, quickly we went through all the different areas. I included some a patient that published his own pictures on the internet here just to show you the typical presentation of the rash on the palms. There's only a few different conditions that will cause a rash on the palms. One being syphilis, so rarer kind of rash. So I think it can help delineate from other types of rashes, and you can notice that um, it does also affect the face. So far, it's been 95% affecting the face.
Understood.
Okay, so And this time we do have an available antiviral. Tpox is the name for it. The generic name is Tosoluzumab. It's available in oral and IV, and the CDC is controlling the supply of it through the local government. You can have a patient start the therapy. They are also enrolled in the clinical trial, so they have to be in the clinical trial to get the TPOX. It interferes with the vir unwrapping process at the end of the packaging of the virus before it gets out of the cell. Um, it, this particular antiviral seems to spawn a very good immune response, uh, likely by exposing um, the uh, the viral antigens to the immune system a lot more readily.
Yeah,
Uh,
because it is stopping it from building a cover around it. So its naked parts are then exposed to the immune system, and immune system would make antibodies. Very interesting.
and this is something that I had found just in research. It seems that resveratrol, the anti-inflammatory, um, and other polyphenols possibly seem to interfere with the mechanism of orthopox virus replication. It seems to interfere with the viral DNA polymerase, and it seems to have an effect on both smallpox and monkeypox replication. Now, the paper that I included did test both monkeypox and smallpox, and this is a paper from, I believe, in 2017. So it goes pre monkeypox outbreak. So it's something that has been talked about before this latest outbreak.
Understood. Thank you.
Okay.
So here we are.
Mhm.
Thank you so much. So let me just quickly see. Thank you for your generous time, and thank you for putting this all together for us to just go through this. And you had actually worked to put all this protocol together. So thank you, thank you, thank you. Let's see any questions here. Um, John says, are children badly vulnerable to monkeypox even though they have been vaccinated with chickenpox?
Well, I think it's yet to be determined with what any kind of vaccination from chickenpox and the orthopox, monkeypox viruses. I haven't seen any kind of relationship between the two. Have you?
No.
No, I haven't seen any.
And let's see if there is any other question. There is a thank you for your time. Thank you, thank you, thank you. So I think that's it. Thank you very much, Dr. Zaharakis, for your time, for all of this work, for bringing us up to speed with the BA5. I actually agree with you. We should name it something else, ASCOV3 or something. And thank you very much for the monkeypox. I actually was curious as well that how you are treating it. So thank you,
You're
and
welcome. Thank you for having me on.
absolutely. And Cool Beans, thank you very much for your time as well. I would see you on Wednesday. I'm traveling to Charleston and I would not be here on Monday and Tuesday. So I will come back on Tuesday at night. I'll see you on Wednesday. And on Thursday, we would also have Sean with us, who had the vaccine injury. He has some follow up as well. And I think these will be important. He had gotten some chemotherapy. He's also getting IVIG again. So it is important to look at his progress so far. So with this, thank you very much. Have a great weekend. And Dr. Zaharakis, once again, thank you very much for being here.
Thank you. Good night.